So, welcome everyone. This is our fourth Inspire Grand Rounds. We're really excited to have you guys here. I'm Shannon Flood, along with Ryan Fredericks and Bram Weltorin. We help to organize these events. And Inspire Grand Rounds really has kind of an overarching goal of highlighting our mid career providers and, in particular, our international experts today. And we really want to be here and help provide a space for some networking, some potential mentorship relationships as well. I'll start by just saying we're always looking for feedback, so please do keep an eye out for a feedback form that's going to be sent via email after today's presentation. We really want to hear from you and how we can make this better. So with that today, I'm really looking forward to our presentation today by Dr. Jabin Fayez and Dr. Adil Khatri. We'll have about 50 minutes for the presentation or so, and then a little bit of time right after the presentation in a large group for some questions and answers. And then we'll plan on breaking out into probably two small groups, kind of depending on the size of the total group, in order to have a little bit more detailed conversations about our reflections on the presentation, and then a little bit of time to share if you're having any current projects or questions you have for Jabin and Adil. So, as a couple of introductions, I will say it is hard to introduce both of these really fine physicians and all of the work that they have done, but I will try to be as succinct as possible. Jabin is well known to the Inspire Network. She is the IPSS and Inspire Fellowship Chair. She's a board member for both Inspire and IPSS, so we know her well. She started her career in Pakistan as a pediatric emergency medicine faculty at Aga Khan University Hospital after obtaining her degree. She then worked at Sultan Qaboos University Hospital, where she implemented the Canadian Triage and Acuity Scale there and worked on several other QI initiatives utilizing the lean methodology. She started her PEM fellowship at the Hospital for Sick Children in Toronto and then followed that with a simulation fellowship. She has her master's in health professional education from Sick Kids and is now working towards her PhD at Harvard. So with all of that education, she has been also working with the Indus Hospital and Health Network to implement a simulation-based pediatric emergency medicine curriculum for the emergency medicine residents and a one-year PEM certification program. So we are really excited to have her here and looking forward to presenting her work. We also have here Adil Khatri. Adil graduated from Karachi University, followed by an internal medicine fellowship from the College of Physicians and Surgeons of Pakistan, where he helped to develop a residency program in internal medicine there. He then took over the emergency department at Patel Hospital and became certified in emergency medicine. He joined the department in 2019 at Indus Hospital and completed the Certified Simulation Educators program through Aga Khan University. He is now the residency program director and simulation lead for emergency medicine at Indus Hospital. He works with both University of Pennsylvania and Sick Kids in programs that develop emergency medicine as a specialty in Pakistan and throughout low and middle income countries. His interests are in incorporating cost-effective simulations into health professional curricula and developing low-cost models and innovative strategies to bring sim out of the big sim centers and to the learner wherever the need is. So with that, we are thrilled to have both of you here today. We are really looking forward to your presentation.
Thank you so much, Shannon, for your very kind and humbled introduction for both of us. Just to let everybody know, Adil will go to the first part of the presentation, and then where he will be telling different programs that he has taken a lead locally, and then some of international collaborators, and then I will going through the scholarly part of it in the second half of the presentation. So Adil, please, you can go ahead and share your presentation.
Right. So please let me know if my screen is visible and if I'm on. Okay. All right. So first of all, thank you very much for providing us with this platform and to showcase work that we've been doing here at Indus. As the title says, breaking barriers with simulation. That is what we are trying to do, and that is what we are going to present today. Dr. Jabin will be, as said earlier, she will be presenting the scholarly part right after I have completed my part of all the work that we are doing on ground with respect to simulation at our facility. So impactful simulations in low resource settings. So that is my main topic for today and how we work along with that. So a bit of a disclaimer, I have no financial association with any of the products that are shown in this presentation. So a bit about the hospital that I work in Indus Hospital and Health Network is a free of service hospital. We have we rely completely on public donations, and the patient is not charged anything for the services that they get. So that is a very unique model by itself. Um, Started in 2007 with a single hospital. That is the one that we are working in currently, and that is shown in my background as well. The one in the forefront that started in 2007, and now it has expanded to a whole network all across Pakistan with at least 4 tertiary care hospitals and 10 secondary level hospitals. Along with that, many rehabilitation centers, regional blood centers, and a lot of different innovative ways of reaching to the people, like boat clinics, medical bus service. Um, we serve a huge number of patients, around 500,000 patients every month. So that is the scale on which Indus Hospital and Health Network is working. With regards to the Department of Emergency Medicine that I am currently associated with, there's a 28 bedded facility. We see about 700 plus patients every day, and 1/3 of that is pediatric load. We have 4 EM faculty and 4 PEM faculty. We have a residency program in place that is a 6-year residency program that is associated with the College of Physicians and Surgeons, and we have 28 residents currently enrolled in that program. These 28 residents are who we see as the future leaders, and not just training on the clinical side, but also being a leader and an educator. We involve them in our all academic activities, including simulations as well. Then we have different programs for the non-trainee doctors, the service-based medical officers for emergency medicine and for pediatric emergency medicine. We have leadership programs in emergency medicine, clinical operations program, and simulation activities that go on within the institute, in other institutes as well. And I will elaborate on those uh, in the further parts of my presentation. And recently, we've also started a tele-emergency medicine with our remote centers to serve the underserved centers where there are no trained doctors available. So we have them on that service. A bit about the healthcare simulation scene in Pakistan. So basically, we are transitioning from the traditional methods of health professional education. And it's a very slow transition. The realization of the importance of simulation in a practical field like medicine is something that is being realized, but at a very slow pace. There are a lot of different myths and pre-assumptions surrounding that, and that is leading to the slowness of the pace. There are sim centers being developed in few big cities, um, in particularly bigger institutes, but the gap is huge, and these sim centers provide facilities to a particular group of people, while the most of the healthcare providers are not able to access those facilities. So that creates a bit of a gap in provision of these kind of educational activities and simulation-based programs. Then there is a lack of trained people who would be able to work as sim educators and people who would take this simulation flag forward. However, that is the point where we are working. So a few of the myths and challenges. First and foremost, to make the health professional education community understand the usefulness of simulation. As I discussed, there are pockets of advancement, and we need to break that myth that simulations can only be done in big sim centers. And that is something that we very often find uh, ingrained into the people that we talk to. It creates a lot of bias that it cannot be done in a low resource or at a center where sim labs are not there. Um, and that those are the myths that we're trying to break. And then there are time constraints. There's a huge load of clinical work on most of us, and it's very difficult to take time out because simulation and this type of instructional activity is something that takes a long time. It needs repetition as well. So those are the things that need to be addressed on our part. This is the most common question that we are faced with. So whenever we talk to somebody about simulation and the importance, it's always simulation is very costly. The answer to it is creativity and innovation. And something that we call in local lingo as jugaad. And jugaad is something that being living and growing up in low resource setting, what we turn up doing is using the available resources to the best of use that we can do in order to achieve our goals. So that is something that we use, the jugaad, and we try to make simulations in the local context with local resources, and obviously it has to be cost effective and mostly reusable and portable as well, because we need to take these uh, gadgets, if you may call them, to different parts where it is needed, as not all learners can come to us. So that is where we are working. So a few of the examples that we have developed in our department for simulations. As you can see here, we generally make things out of household items, kitchen materials, and things that are available in the hospital. So we've used some laundry materials like the brush that you see here and kitchen sponge, and made it into a defibrillator paddles. And we use apps on our tablets or cell phones to simulate the monitors and defibrillators, and it creates a very relatively good fidelity when it comes to actually running the scenarios. Similarly, pulse oximeter, we've just made it out of a cardboard, stick some tape around it, put it on a gloved hand that we have as a mannequin, and that then makes the pulse oximeter go on the monitor. Obviously, it is manually, we handle the monitor manually, but to the learner, it is a good fidelity and has resulted in good results amongst the residents who have been part of simulation when it comes to attaching the monitors as well. Another example of trichothyroidotomy model, we have made it out of styrofoam and some paper sheets that we have. Uh, and we've used the ventilator tubings as trachea and cricothyroid. Stick some tape on it to make cricothyroid membrane, and it simulates the cricothyroid model very well. For us, the importance of these kind of models is twofold, because the commercially available models, even if somebody donates those models, it has a bearing for the running cost, because you have to replace all those replaceable parts of the model, and that becomes then costly in the long run. So DIY home developed model this way helps us a lot. The laundry basket model, a very successful one. We use that for chest intubations. Uh, we've been doing this for since 2018. We've upgraded it to a different kind of a model where it now can spew some blood out when the chest tube is inserted, and there is bubbling of air in the underwater seal as well, um, along with that. So it creates that effect of better fidelity for the learner. Some of the other task trainers, a pajama model, you can see crowning and then baby being delivered. We can simulate an obstructed labor with that. Ice cream bucket and made it into a pelvis. And we can actually, what we can do is make a obstructed labor and then shoulder dystocia, those kind of common things that may be seen in the ER, and we can simulate all those things. Similarly, we have these two eyes that we use for, these are our lateral canthotomy models. We've made IV models out of those long balloons that we use for children to make those little puppies and those things out of. So, and the fun part is that when you insert a needle into it, blood comes out. So that creates a bit of a sense of achievement for the learners as well. The priapism and testicular torsion model that we can be made out of tire tubes. We put some tire tubes in, stick them around, and then using a glove box, the common examination glove box, we use that for creating this model. The IO model is made out of plaster of Paris. That's very easily available here in the emergency. We've wrapped some cotton on top of it and put some thin foam sheet on it, and it creates a good sense of when the needle goes into the bone, and there's that give. So again, gives a sense of achievement for the learner as well. Next slide, please. All right, so this is the lumbar puncture model. The vertebrae are made from those laundry clips that people use to hang their clothes with on the line. And we've put some gauze around it, put it in a kind of a tray, and made it into a vertebral column with the paravertebral muscles. We put a balloon again in that, and when we put the lumbar puncture needle in, if it's inserted properly, the fluid comes out. So again, some sort of fidelity to that model. Next slide, please. Simple model made with cardboard, making into a sort of a pinhole camera kind of a thing that some of us may have used in our childhood as a toy. But what we've put inside is images of retina. We can use any image of retina and simulate and teach our learners how to do in ophthalmoscopy. And it's pretty useful in testing them, as well as teaching them how to maneuver the ophthalmoscope as well. uh, trauma-related different models. Again, all of these are reusable. Burns model on the hand, on the arm, as you can see there, and a glove that we can wear with tendons visible. It's just made out of toothpicks and some Play-Doh, and put some color on it, and there you have it. A bleeding arm that we can show as arterial bleed, and maybe some pressure dressing or a tourniquet can be applied on that. Next slide, please. So on to our ultrasound guided models. What we use is a simple sponge. We've had some experimentations done with gelatin and everything, but what we saw was that those models, it's very difficult for us at least to obtain gelatin around, and it's reusable, but after about 10-20 times you use it, then it becomes we cannot use it again. So what we've done here is use a kitchen sponge that people use to clean their counters with, soak it in water, and put some straws and balloons in it to simulate arteries and veins, and it gives a very good fidelity for needle manipulation and hand-eye coordination with respect to central line insertion or with ultrasound guidance. The second part on our right is where the dilatation and guide wire insertion, and then on top of that, the central line can be placed. Again, as you can see, it's a sponge, and we've put some straws in it to make vessels that people can actually work on, just like they're putting a central line in. Next slide, please. A relatively recent model, we've made a pericardial effusion that can be seen on ultrasound. And again, if the scenario dictates that it needs to be drained, it can be drained when with a needle as well. It's particularly used for trauma scenarios with cardiac tamponade. And as you can see, the heart is moving. It's just a balloon filled with water, and we're pushing it from the other end, and it creates a sense of movement of the heart. So just a balloon, some kitchen sponge, and a lot of creativity involved. That is what made this possible. Next slide, please. A few of our activities that we do, tabletop exercises using Lego pieces, keynotes, Jenga blocks, and we've made different maps of our own emergency, as well as when we do a multi-hospital scenario, then we assign different different sized hospitals, create a city within the area that we're doing our tabletop exercises, and then do a disaster management drill with all these toys that we have available with us. Next slide, please. Mock drills. This video is actually part of one of our trauma courses, but we've been doing these mock drills within the department, as well as in different institutes all across the country, as well as now expanding to Vietnam, Ethiopia as well. So, so ever expanding, I'll touch on those different programs that we do in just a bit as well. Next slide, please. So our SIM journey, it started in 2018 with our flagship program, the certification program for emergency medicine. And then in July 2019, we integrated simulations into our emergency medicine residency program as well. We have weekly sessions every Friday, and simulations are part of those weekly sessions. Then in September 2019, we started the Collaborative Advanced Trauma Care Program in collaboration with Emory University in Atlanta, USA. The certification program for emergency medicine initially started with Bingham and Women Hospital in Boston, and later on, we're now in collaboration with University of Pennsylvania. We've had our first case of COVID-19 in early 2020, and then that is where, due to restrictions, most of our activities got. We've had to think a lot of different ways on how to continue in those times, and that is where innovation again played its role. Next slide, please. So we started to go online initially with our didactic sessions, but as you know, just didactics do not suffice. We went on to explore different programs, and with online simulations and hybrid learning, what we were able to do was to expand from our hospital and from the city nationwide. And then later on, next slide please, to international, into the international arena as well. So two of our programs, in fact, three programs are now based not just in Pakistan, but also in other countries as well. What we do with online simulations is we use the virtual research room. We use it for synchronous learning when on a Zoom call, and this is basically we use it for teams management and how people would work in a team in order to manage a patient while doing simulations. And then we have affinity learning platform that we use. This we do use for synchronous as well as asynchronous, that the learners can actually solve these cases on their own time at home as well. And then we have a full code application, which is a slightly higher fidelity, sort of a gaming platform, where we have our learners go through these cases on a Zoom call while doing a simulation online, synchronous simulation, and they can do it on their own times as well, based on the assignments that are given for their programs. Next slide, please. So, click, please. So in 2020, July, the certification program in emergency medicine went online, and we realized how good it was to expand our horizons and move ahead with those things in our hand. So in August 2021, we started the first SIM-based pediatric emergency medicine module for our residents in collaboration with Sick Kids Toronto, and Javeen has been with us since that time and has been a key factor all our activities. After that, in July 2022, we started our development of simulation educators and simulation instructors. Four different workshops have been conducted with regard to that. One of them has been at a separate.
Sorry, Adil, your voice has gone a little bit down, become slow a little bit.
Am I audible now?
You just got really, really quiet all of a sudden.
Am I audible now?
Still too quiet. Thanks for working with us.
Sorry.
Oh, that's better.
Yeah,
That's
okay.
better. Yeah.
Right. So from January 2022 till date, we've had 3 simulation instructors workshops. These are 3-day workshops which introduce the simulation educators to different aspects of simulation as well as the standards of simulation. We've had one workshop with a medical university, medical college, as part of their training for their faculty as well. So we're working on collaboration with different institutes within the country as well. If they are interested in any training with regards to simulation for their faculty, we've started doing that as well. In August 2022, we've had the second cohort of our PEM curriculum for residents. And this time around, we had a few residents perform as co-facilitators as well. So we're developing the residents and the faculty within our own programs to work towards becoming a faculty on simulation as well. Next slide, please. A bit about our different programs. The certification program in emergency medicine, the CPEM, it started in July 2018. Four cohorts have this. Currently, we are in our fourth cohort. 3 have graduated. It's a 12-month competency-based training. We take 30 participants each year. We've had participants not only from Pakistan but from Bangladesh as well. This includes distance simulations as well as in-person simulations as workshops that are conducted within the country. And for Bangladesh, we did these workshops in Bangladesh as well. Local and international facilitators from all over the world have joined us for this program, and it has been a very, very fruitful in the sense that now it is coming a full circle where the graduates have now started to come and teach as facilitators as well. Next slide, please. Then we started the foundation program in pediatric emergency medicine last year. We're in the first cohort currently, and this is again a distance simulation based program with VRR and Affinity platforms. We have 28 participants this year, and it includes about 50 simulation hours per learner for this program. The simulations are not just synchronous but asynchronous as well, where they're given assignments and they have to do those asynchronous simulations and then are tested on that as well. Next slide, please. The collaborative advanced trauma care program started in 2019. We've had 5 cohorts nationally, and then 2 in Ethiopia and 2 in Vietnam. Recently, we have also started a training of trainers program for Vietnam and are planning to do a training of trainers in Ethiopia as well later this year. About 320 participants have been trained in this program within Pakistan, and we've had some local and international facilitators for this. This is being run in collaboration with Emory in Atlanta, Georgia. The main focus of this program is interprofessional teams and interdisciplinary collaboration for management of trauma and in the emergency and in disaster situations as well. This is a very simulation heavy program that is a 3-day course with more than 15 hours of simulations per cohort. Next slide, please. So we come to the development of simulation instructors and educators within our setup and within the country as well. We started the first simulation instructors workshop in January 2022. It was a 2-day workshop and was very well received. There was some feedback about it being very fast paced, so we changed it to a 3-day workshop in March 2022. And a lot of interest shown by different faculty members, not just from my own institute, but nationally as well as internationally as well. We've had learners coming in from Saudi Arabia and India as well. Then we did a workshop with the medical college, the Pakistan Air Force Medical College as well. And it was a privilege to go there and do a simulation workshop, since we all know that Air Force are the pioneers of simulation in their field. And now here we are going there and doing a workshop on healthcare simulations. So it was a matter of a bit of a high for us in that regard. Then in November, the third part of this simulation instructors workshop. And now in this year, 2023, we are planning on doing all these workshops that were done in the previous year were online, and in collaboration with Dr. Jabin and a few of our colleagues from the Western Hemisphere. But now in July, we are planning on doing a hands-on workshop with a bit more details to it and a bit more hands-on training. So next slide, please. And then we move ahead and we are planning on launching a certification program in simulation. So what impact has been created is that we have 500 interprofessional educators trained in basic emergency care, trauma care, and pediatric emergency medicine. Click please. Sim training for 68 faculty members in Pakistan, India, Saudi Arabia, and UK. Next slide. In we've had facilitators and faculty coming in from different parts of the world. We've had 28 different facilitators come in and share their ideas, and that has been a very big bonus for us. Next slide, please. So our future goals include continuing the capacity building measures, increasing focus on simulation-based research, which we are not currently very good at, but we're slowly moving towards that, understanding how to do research in educational activities as well as for simulations as well. Representing Pakistan in international SIM forums, increasing the collaboration with local institutes as well, and launching of a simulation certification program. One of our goals in long term would be integration of simulation-based education in MHPE degree programs as well as undergraduate programs all over Pakistan. And then preparing the new generation of sim educators and innovators. So these two pictures are very close to my heart. These were taken by me at about 3:30 p.m. in the morning. And I was just walking through the corridors of our department, and I saw two of my residents trying to work on improvement of one of the models that we had for labor, and they were trying to make some innovation into how to use it for peripartum hemorrhage. And these are the things that they were working with, a Foley's catheter and a balloon, and they were trying to improve on the models that we have currently. So very close to my heart to see my residents joining in and trying to improve what we already have. So with that, I would like to thank you. Next slide, please. I'd like to thank you all for your kind listening. This is the hospital that I work in. It's in my background. That's the nighttime picture, and this is the daytime picture. The big hospital, the big building that you see is the under construction hospital. It would be a 1100 bedded hospital, all made from donations, as we do not charge the patients at all. So, thank you for your kind listening.
Thank you so much. You can ask anything that you want to ask. Meanwhile, I'm trying to share my presentation, and I'm going to go a few things of the scholarly work that we have done. And this all work which Adil has shared is very close to our heart, because we are trying to make some difference in patient care improvement by just doing and volunteering our time for these educational activities and interventions. So thank you so much, Adil, for presenting what is very, very close to my heart as well.
Jabin, one question that Tensing brought up that's timing wise might be nice to ask now is there a possibility to share the kind of recipe book that Adil was referring to? And that would be pretty amazing to be able to kind of have that at other people's disposal if possible. Don't reinvent the wheel.
Yeah, definitely. That's what I'm pushing, Adil. Adil, you have to write down everything what you are creating so that other people can utilize. He has such a creative, like every time I get a text, Dr. Jabin, this is what we can do. I say, yes, for sure we can do. So this is our kind of in our bucket list that we have to do. Very good idea. So Adil, you have to do it now. Perfect. With this segue, not as fascinating as Adil's presentation, but I'm just going to share some of the research work that we are going to, that I'm doing in collaboration with Adil and all my amazing group in Inspire, IPSS, and my PhD Harvard colleagues. I do not have anything to disclose. The first study, which I'm going to share, is a part of my PhD study as well. And I would want to, I say I don't have disclosure, but I want to disclose that I will be giving a very much higher level views of these studies. So please feel free to connect with me if you want to know more detail. And I hope we will left with some Q&A at the end so that you can ask me if you have some more questions or clarification needed. So the first one, when we implemented the PEM module at Indus, we started this project by by implementing a culturally adaptive pediatric emergency medicine curriculum through distance simulation using the virtual resuscitation room in Pakistan. The first part was the quantitative study, and our aim is to look at this implementation based on the Kern's 6-step framework. And the Indus Hospital details, if you can scan this barcode, you will find several barcodes in my presentation. And if you want some detail, you can definitely scan them. So what we did, we just follow the basic steps of Kern's framework of curriculum development. We started with problem identification and a journal need assessment by doing creating a working group with the local stakeholders. And we up till now, since that time, which is almost third year now, we are meeting each week with that working group, and we do look at what is happening. We keep on monitoring, we keep on evaluating, and then we make some plans for moving forward. And why I like Kern's 6-step framework, because it is not that a longitudinal framework where it goes from idea to implementation and evaluation. It's a circular model if you look at Kern's framework, so that each part of or each step will inform the forward step, also the forward step inform the backward step. So after making this working group and having a scan of journal need assessment, we conducted a targeted need assessment with the Pakistani EM resident, and we did the focus group with the EM residents and the previous residency coordinators as well. The goals and objectives were created using the Bloom's taxonomy. And also we looked at the PEM curriculum, which is implemented locally, and me being the fellowship coordinator, fellowship director for the PEM fellowship program, helped me to look at the various curriculas in the North America and then some local setting. And then we come up with some of those goals and objectives. The educational strategies, we targeted it multifaceted. We provide them with the pre-reading material and pre-recorded lectures on the Google Classroom. The distance simulation, as I'm going to allude later in my presentation, were used by doing virtual recitation room. And we have a case-specific checklist. And we did develop or revamped our scenario, which are more culturally adaptive to the Pakistani context. And that also I'm going to explain in my next slides. Implementation, we get the leadership buy-in as well as stakeholders buy-in. We did a pilot session. We did our dry runs to look at the internet availability, connection availability, and their ability to work with us on the virtual recitation room, and some of the faculty development in facilitation, as well as doing using the Pulse debriefing framework. And the evaluation continued by the course evaluation, as well as the learning evaluation of the learners by pre and post test, which is MCQ-based test. The team score, which is team emergency assessment measure, to look at the leadership, task management, closed loop communication, and then we conducted a post-module objective structure clinical examination as well. So when I say that the cases were culturally adaptive, what I meant is we looked at some of the Pakistani cultures and beliefs and customs, and also the case specifics, which are very much specific to Pakistani context. And some of the example that I want to give in is, for example, even a simple acetaminophen is called Panadol here, is called Tylenol here, but Panadol in Pakistan. The lab investigation measurement units, how they perceive the healthcare access issues, vaccination hesitancy, protein calorie malnutrition, which is not present in this part as well as it was, as much as it is present in the local context of Pakistan. Like almost there is a separate unit for protein calorie malnutrition on the floors in each hospital. So that allude to the problem of some of the local problems that are very much local. And then we incorporated in the scenarios some difficult situations like lack of education, lack of understanding of the disease, precedence to a male child in comparison to the female child. So the timeline of PEM curricula, we have conducted up till now 2 cohorts. So the first cohort was in 2021, which you can see on the left-hand side of the table, which was started in August 2021 as a pre-test MCQs. In 2021, there were 21 Pakistani EM resident because it is a 6-year residency program. Every year, there are new residents are recruited. So that's why in August 2022, there were 27 Pakistani EM resident. Then we run this 8-week PEM module through distance simulation. And then in October, we did the post-test MCQs followed by OSCEs. In throughout this 8-week, each week there is a team score assessed over this time period for each team, both in 2021 and 2022. The distance simulations were conducted using VRR. If you want to go to this website of the VRR, scan the barcode, or just write down VRR and you will find it. Why we chose it? Because it is easy to use, it is freely available, collaborative, and it will provide an opportunity to have interactiveness, and it's very responsive for the action, and the facilitators can respond to the vital signs. So it is for simple to understand that in normal scenario, what happened? A sick patient come, you work as a team, and then you learn from that, and later on you debrief. So it is either in your in situ simulations or in your sim centers. But what VRR do, nothing changes. Only the platform where you do sim become the VRR. And then you need a Zoom and a Google slide, and that's it. This is like a screenshot of the virtual recitation room bay. This is the virtual medication cart that we use in VRR and the virtual airway cart. And then you can see everyone on their own laptop interacting through the Zoom and the Google Slide platform. So these are some of the examples of the sim session in action. And then coming to the most exciting part, that is the results of our study. So you can see the level of the training, and they are from PGY1 to PGY5. There is 66.6% were females. If you look at the need assessment survey, which is a very big eye opener for me, that participation in the pediatric resuscitation, almost more than half have never participated in the pediatric resuscitation. And when we ask them, when you have led the last time the pediatric resuscitation as a team lead, 51% said never. And then how many resuscitation led as a team leader? 55% again said none. So you can see how much this module was needed and how timely this intervention was. And then when we asked them about their confidence in leading the pediatric resuscitation, 51% strongly disagreed that they felt confident in leading the pediatric resuscitation. The need for simulation-based training was perceived by all as we need a simulation-based training because they are introduced through the certification program in emergency medicine, that how effective and beneficial is simulation for their learning. And the virtual platform acceptance is very high. So it is a kind of a very fertile ground for us to just start something for PEM. Coming to the post evaluation of the post test in MCQs in 2021 and in 2022, you can see there is an improvement from pre to post based on this box plot. And one can argue that you are doing the same program with the same resident next year. So is it going to be beneficial? That question we do have in our mind, but you can see from the result that there is an increase in knowledge, although not as much as it was in the first time. So you can see here, the left-hand side is the first time when they did the module, and the second time, well, the right-hand side box plot is when they did it second time. So yes, the improvement does not happen much, but there is still an improvement, which apply with the adult learning theories, that repetition in those areas which they are not very comfortable and not used to do much will bring still some improvement. This is an interesting chart about the team score, which I want to draw everybody's attention. These are 4 graphs, and I'm going to explain them in a minute, all of them. On the left upper, the team score has got 4 domains: the leadership, the teamwork, task management, and the overall performance. The left upper is the leadership one, the left down is the task management, the right upper is teamwork, and the right lower is overall performance. The red line, which is going in between the graph, is showing an overall improvement. So you can see in all the graph, there's an overall improvement that happened over the 8-week, but you can see some dips here. That is the neonatal resuscitation, the central nervous system, and the protein calorie malnutrition in almost all domain. And when you looked at the literature, these are the 3 areas which are considered as halo event. And people, even the EM resident, if you look at the literature, many have postulated that the EM residents did feel uncomfortable in these areas, so which is not a very much of surprise. I am a PEM trained physician, and I still felt uncomfortable, especially when it comes to the neonatal resuscitation. End of session evaluations, we found it high satisfaction by the learner. It is relevant to their cultural context, and the facilitators provided them with a safe, non-judgmental learning environment where they can learn as teams and grow as a team. The second part of the study was exploring the cultural sensitivity of physicians and simulation educators in the same module. And what we did in this study, the overall goal for this project was to explore the cultural sensitivity through the EM medicine's resident as learner and the Yale PEM fellows as facilitators. We all know that the culture do not hold any boundaries now. We all live, like I am in Toronto, but I come across so many varied cultures. Same is true for Pakistan, for India, for Bangladesh. They do have cultures within their own cultures. Like if I go from one province of Pakistan to another province, there are multiple cultures, and that is true for all over the world. So geographical boundaries are non-existent anymore, and cultural competency is essential, but we see that it is not a very core part of our curriculums. If you look at the CanMet's role, which a residency program, a resident is, or a fellowship program, a fellow is expected, the cultural aspect is not very explicit in it. Our healthcare system must strive to provide treatment and services that are culturally appropriate and effective to all the cultures, irrespective of their geographical location and their background. So that's why the culture exploration is very important. And I just want to take a pause here to go through an important concept of culture. If you look at how to define a culture, it is very, very difficult to define a culture. But if you look at Hofstede and Leninger in 2011 and 2006, they define the learned, shared, and transmitted values, belief, norm, and life way of a particular group or individuals that guides thinking, decision, and action in a pattern way, which is also often intergenerational, is called a culture. So I really like this iceberg model of culture. It is provided by Edward in 1976, and it compared the culture by an iceberg, where the upper part of the culture, which you see that we all are seeing each other right now, is the way how I speak or how anybody else speak, how I dress, what is my language, what is my literature. But it is only 10%. The surface of the culture is only 10%. The rest of 90%, which is more about values, tradition, beliefs, is the base of the iceberg, which is 90%, and we have to understand it more. Also, if you look at the literature, there are many or terminologies are being used. And when I was exploring them, that what is the best way to do my research, so I was becoming so confused that whether it's awareness, whether it is sensitivity, it is competence, or humility. So I would say that awareness involves the ability of standing back from ourselves and becoming aware of our own cultural values, belief, and perception. So with this, you move on to cultural sensitivity, which is employing one's knowledge consideration, understanding, respect, and tailoring after realizing awareness of self and other, and encouraging the diverse groups or individual, and this will increase your understanding, which will move on to the cultural competence, which is the ability to understand, appreciate, and interact with people from different cultures and beliefs. And then the cultural humility will come, which will be like that you become a lifelong learner, because culture is not that I got a training or I'm in a certain point, I am culturally aware or sensitive. It is a lifelong learning, a commitment, and self-evaluation and self-critique that I continue to learn from my own culture, as well as the cultural interactions that I have around. So I really like this metaphor of cultural lens, which is a good way of thinking about differences. Believe me or not, we all have our implicit or blind spots, and we all wear a pair of invisible glasses that shape how we see things around us. So being culturally aware is not about compromising your own culture or sacrificing your own values or identity for other. It is simply about helping us understand how we can best adapt our approaches. So with this context, what we did, we aim to establish an intercultural distance simulation experience between Yale PAM Fellow and emergency medicine resident at Indus Hospital Health Network, Pakistan, and then to understand the cultural competency among PAM Fellows at Yale and EM resident in Pakistan through distance simulation. It was a mixed method study, and for the quantitative method, we utilized the clinical cultural competency questionnaire and its analysis to assess the knowledge, skills, attitudes regarding the cultural competence. And the qualitative methods were the focus group and qualitative content analysis after the curriculum completion. Our participants were 22 EM residents from Indus Hospital and 8 PEM Yale Fellow. As you know, the setting was in Pakistan, in Karachi, and Karachi is one of the biggest cosmopolitan city, 12th largest city of the world. And then you can see the linguistic diversity of Karachi, how many languages are spoken in Karachi. So what we did a baseline clinical cultural competency questionnaire, we run the distance simulation, and then we conducted 3 focus group after curriculum completion. So the clinical cultural competency questionnaire, you can scan for the further detail. It is developed by Like RC for a European context and later on in 2001. And it has been since then shown a good validity evidence and reliability for many different cultures and being tested in nursing, mostly in nursing literature and the undergraduate literature. It's a big questionnaire. It has got demographic characteristic, knowledge domain. I'm sorry for a busy one. It's just like I want to show you a glance. How does the questionnaire look like? About skills, about their attitudes, and then about the education and training. In terms of the quantitative result, you can see the demographic here, and I'm showing them side by side, but my intention is not to compare these two population from Pakistan and US, because it is not an intention to compare their cultural competency or compare their CCQ questionnaire. You can see their diversity. They are from diverse ethnic background. And then when we ask them, have you visited or lived any countries outside your own country, 17% of Pakistani EM learners have lived, while 100% of the US residents or fellows have lived or visited outside. And then in terms of their linguistic diversity, 94% of Pakistani learners speak other languages, while 100% of the US learners speak other languages. If you look at the knowledge, skill, encountered, and attitude, they are in the middle, it is from a Likert scale of 1 to 5. So you can see in all the domains, the values ranges from high 3 to low 4. But the interesting thing here is to note is that when we ask them, did they get any knowledge or information about the training, about the culture in their college and medical school, which is about to negligible, and they start to get some training about the culture in the residency and fellowship program, which is kind of a alarm or alert for us to incorporate such training early on. The qualitative analysis of the focus group, we did a content analysis, and these are the 3 themes we come across. That is the learning experience, intercultural counters, and challenges. In the learning experience, everybody mentioned that training has been a very rich learning experience for them, not only in terms of the PEM, but also in terms of the culture, in terms of counseling, understanding parents and their worries. They also mentioned that they have learned to ask for help without shame to colleagues. While Yale PEM fellows, several of them mentioned that they also wanted to learn from colleagues in Pakistan about their work dynamic and work environment. Some fellows from the Yale had limited experience as simulation facilitators. Therefore, they felt nervous in the beginning and uncertain about their own knowledge and skills, but then later on found it a valuable experience. When we go to the intercultural encounters power distance, the data highlighted that the US were seen as a standard of how to practice pediatric emergency medicine, both by Yale PEM fellows and the Indus EM resident, and Pakistani medical reality was seen as a stranger, the alien, and US as the medical standard. And the expectation seemed to be that the Yale PEM fellows will learn about the cultural aspect, while the Indus EM resident will learn about the PEM. And then both sides appear to be quite surprised that they were surprised at the end that they are learning from each other both aspects, and it's not true. I'm like in terms of the language, several EM resident needs mentioned their needs for prayers, a break to fulfill their praying duties, journal awareness about the ethnic, cultural, and linguistic diversity within their own country was missing by the EM resident, and they said that they haven't paid attention to those aspects, especially in the emergency medicine, counseling, and interaction with the parent. While the PEM Yale fellow said that need for prayers break was perceived as interesting, and they did not further discuss it or talked about it. And then several Yale Penn fellows stated that they did not perceive any cultural related differences in medical training. And they actually said that the language of medicine bring them together. So I'm just skipping a couple of for the sake of time. Some of the challenges technology related are the internet connection, electronic devices, because everybody did not have their own laptop. So VRR does not work well with the phone. And the Yale Penn Fellow recognized challenge of dividing and conquer during distance simulation. Chat window was found to be distraction, but also a helpful tool for their communication. The pre-briefing and orientation to virtual space was helpful. For scenarios, it was found to be very much near to their local context. Particularly, we paid a special or intentional consideration to convert them into a local context. For the facilitation, it was felt very much collaborative effort. In the beginning, the EM residents were shy and hesitant to ask, but later on, it became very much collaborative. In the debriefing, the interesting fact was that they switched to Urdu language in between, which the FEM Yale fellow will not be able to understand. So they said having a local facilitator was very helpful in that moment. So strength, the overall results show that distance simulation training helped cultural understanding among the learner, and the focus group allowed us to explore it further, to have a deep dive, and it opened the space for further discussion. The limitations were inherent challenges of the distance simulation. Focus group on the Zoom did not enable us to have the non-verbal cues. And then it is in the very specific context. So the generalizability of this data, it can provide as a roadmap, but having said that, it cannot be generalizable to all the setting. So with that, I will go to the last part of the video, and I'm skipping the third study because of the time. And these are some of the references, and I will end the presentation with this video.
My name is Dr. Saima, and I'm one of the consultants at the Department of Emergency at the Indus Hospital, Karachi, Pakistan. Working in a country with a population of more than 200 million and based in a city which is the 5th most populous city in the world, our challenges are numerous. From overpopulation to underprivilege, from lack of basic healthcare facilities, leading to untoward events, lack of infrastructure, lack of manpower in healthcare, and the recent pandemic with urban flooding. Our challenges are numerous.
अपने पेशेंट का जो ब्लड लॉस है, पेशेंट के शॉक को ट्रीट करना है, ठीक है? आपने स्पाइन बोर्ड लगा दिया, आपने स्पाइन प्रिकॉशंस ले लिया, आपने फिलाडेल्फिया कॉलर लगा दिया. That's fine.
Here at the emergency medicine department, me and my colleagues, we aim to bring about change in the emergency care delivery by training young aspiring EM physicians in terms of clinical research, with evidence-based training programs inculcated with simulations.
81 years old. He's accompanied by his wife, and he has just fallen downstairs at home. Nurse, blood pressure 90/50 है. How are you guys feeling while we were doing this sim? These challenges are what make us strong. We face them together as a team through our resilience, through our capacity building, through our focus on the future, through training our future EM physicians. And we strive for it every day.
along with
We hope for a better future, not only for our own hospital, but for a better healthcare structure across Pakistan. Our philosophy is never to give up, to rise above the ashes, to reinvent ourselves, to meet the challenges of the new millennia. It is through our shared strength and hope in each other that we hope to make EM a rising and aspiring field in Pakistan. और क्या हम अच्छा कर सकते हैं? ठीक है, thank you. Round of applause, yeah.
So with that, thank you so much for providing us this opportunity to share all our work. It is all the work is done in last 3 years. So it is very difficult to just summarize it in such one presentation. And I think we are so passionate to show every one of you. So thank you for all your patience listening. And we are open to, me and Adil are available for any clarification or question.
Thank you so much, Jabin. We appreciate your thoughtful presentation. And thank you to Adil as well for his excellent part on this. And again, on behalf of the Inspire leadership and our Grand Rounds Committee, we apologize very sincerely for the interruption and the security lapse in the middle of Adil's talk. And we applaud him and thank him for taking it in stride and continuing. We apologize we lost a few minutes of your presentation there. So at this point, we'll move to questions. We'll all stay together in the same room in the interest of time. If anyone has a question, either for Adil or Jabin, please feel free to unmute, raise your hand, put it in the chat, any of the above. Shannon or Ryan, if I don't see something in the chat, please bring it to our attention, although I do have so many screens open that hopefully I'll see things pop up. I can start us off actually with a question for Jabin. I was really interested to hear your comments about culture there, how it's defined, how it manifests itself in people's responses to curricula and in thinking about how you design curricula. Any thoughts about different cultures within the hospital and different consultants or other specialties that people in the ER on either side of the ocean may interact with, and any differences you saw either in designing curricula in the studies you did in one group or the other?
Yeah, that is a very interesting question. Actually, what I found, which is very fascinating for me as well as the Pam Yale Fellow when they become facilitator, that we do ask for help very early on, which is not considered as a good thing in their culture. They call the consultant or ICU when the patient is already, even they put central line in the emergency department, and then they call the ICU. And I have, why you are not paging consulting IC, why you are not informing them you have a sick child? And we have a lot of conversation about this. So that is the biggest difference I found. And then the other thing is the intention to do everything all by yourself. It is just like that kind of a I don't know what it can fit a little bit in a power distance realm, but that is the biggest thing for me that I realize, which is very much like stand out. And Adil can add on if he has something else to add on.
Yes, I hope, yes, I'm audible. So, yes, I agree to that. There's a tendency to do things and not ask for help. There's this resistance towards that. It's slowly we're getting away from that aspect, especially asking a senior. You need to give it a good thought before you go ahead and ask something from them, because you're always scared that they may find something wrong with what you've already done. And so that there comes the power and hierarchy slash cultural thing. But slowly things are getting different. The new generation is slightly more open to asking and asking questions even. Like we think that this is how it needs to be done. So we're getting there slowly but surely.
I'm curious, Adil, when you say that people are hesitant to ask their seniors or ask consultants, is it more from the side of things that they feel like they should do more and kind of handle it on their own end? Or is it because when they talk to consultants, there is some concern with talking to them or some pushback, or, you know, like, why are you calling me? So which side do you feel like that's on? Is it from the learner or the PEM side, or is it more the consultant side that you are anticipating some potential issues or pushback or whatever it is that you're seeing?
It's a bit of both, actually. In the old times, it used to be more on the consultant side, but as things are moving along, it's now a balanced kind of a thing where the junior doctors feel like they should be doing more stuff independently as well, and they have that liberty to do so. But there are situations where they feel a bit shy in asking. I'm using the word shy in a very conservative manner, but that aspect still exists. Yeah, still.
So the way the consultant evaluate the learner who call the most is not a good learner or not a good resident. He do not know how to work in his shift. So just
Yeah,
a metaphor.
it used to be like that a lot, but things are changing. People are more receptive now as things have moved along. So it's kind of both ways.
That discussion of calling people, and I'm going to put the link in the chat, but I think that probably reminds some of us of a qualitative study Walter Epic did a few years ago, literally looking at phone conversations between junior doctors and calling subspecialty consultants from other services, and trying to figure out what was the hidden curriculum there. Don't call me is one part of it, but there's a lot more to it too. But in the interest of time, I've put it into the chat if anyone wants to take a look. Other questions from anyone else?
I was just curious, kind of on that same thread, how many of your simulations are just purely with the residents or the trainees, and how often do you get to do interdisciplinary simulations or sims with some of these other consultants and kind of join them in when we're kind of talking about these differences in culture kind of within the hospital?
That is,
So,
yeah, I mean,
yeah. I would say since the residency program is the biggest program that we have, runs for about, it's a 6 years training program. I would say about 35 to 40% of our simulations are with the residents. And that just is not the clinical simulations. It's the residents are also involved in other things where they need to be facilitators as well. So it kind of goes. The residents, when they become senior residents, like year 4, year 5, year 6, then they assume roles of facilitators, and in the final year, we actually have them evaluate the junior residents as well for their annual exams, so they can get a taste on how exams are done. Other than that, our 2 certification programs are there. Those are done every week. I would say 40% that, and then nurses training and other interprofessional is about 20%. We're working on increasing our coordination and more programs with the nurses. Um, they have their own schedules. They have their own teaching services with the nurses evaluations, nurses education services as well. So things are we're working on that part. Um, a few of our programs are inherently interprofessional though, so nurses are involved in those, but we're moving towards more collaboration with nurses education services.
yeah, and then to add on to Shannon, that we are intentionally making effort now whenever we do anything for professional development or faculty development, we are starting to reach out to our nursing leadership to provide at least one facilitator or one faculty from their nurses to be part of those simulation instructor workshop. And with Jinasen Medical University, we are incorporating this simulation 3-credit module into the master's program. And for that also, we have specified 1 to 2 positions for allied health professionals, in addition to the medical or doctors, physicians, faculty, basically.
I think that's a wonderful piece to add, Jabin. I think, and this is different in different cultural contexts, but I think in medicine in general, there's still such surprising gradients of authority between different professions within healthcare, even at times where there shouldn't be. And the program I've worked in here in the US, in Houston, we've noticed amazing kind of off-label, if you will, benefits of just having the nurses see the physician's thought process. And so one of the things that I'm trying to work on and trying to teach our trainees, and by extension our faculty, is just share your thought process more, right? And suddenly you get more out of your teammates from other professions, and you actually get more specialized knowledge from them that you yourself actually don't know, just by the act of including them and giving like even the most simple of shared mental models and even the most simple of cases. So pretty powerful stuff. So again, thank you so much, Jabin. Thank you, Adil. Thank you to all the participants who've been here. We really appreciate everyone's time. We appreciate everyone sharing and being involved in the dialogue, being involved in the questions. There will be an edited version of the recording available later for colleagues who couldn't make it, that people will have access to who signed up for the event but weren't able to be here. And if anyone needs anything offline relating to this presentation, please feel free to reach out to any of us who are the hosts, or via the Inspire office through the emails you've gotten from Inspire. So thank you again so much to Jabin and Adil in particular, and thank you to everyone for participating in Grand Rounds today. We hope to see you at future events. The next big Inspire event being Inspire at IPSSW. So hopefully many of you will be there. And we wish you a pleasant rest of the day, and thank you again.